Chapter 2: The Human Damage, Patients in Debt, Doctors in Despair. This is not a medical drama. There are no heroic rescues or miraculous recoveries. This is the lived reality of American healthcare. A slow, bureaucratic erosion of health and hope, where the very system designed to heal instead inflicts two distinct but connected wounds: financial and moral. The patient's nightmare, the business of suffering. In the United States, medical necessity is often subordinate to financial calculus. Diagnostic tests, life-saving treatments, and specialist referrals are routinely delayed or denied, not based on clinical judgment, but on cost containment algorithms. Appeals processes are labyrinthine by design, with patients forced to navigate opaque systems while their conditions worsen. This is not an occasional error. It is a systemic pattern. Denial of care has become a normalized function of the insurance apparatus, where delay is a tool and inaccessibility is a feature, not a flaw. A diagnosis of debt. A medical crisis in America is rarely just a health issue. It is a financial catastrophe. Medical debt is the leading cause of personal bankruptcy, a uniquely American phenomenon among industrialized nations. This debt forces impossible choices between treatment and rent, medication and groceries, survival and solvency. Data shows that patients burdened by medical debt are significantly more likely to delay care or forgo prescriptions, directly worsening their health outcomes. The system, in effect, monetizes suffering and penalizes illness. The deliberate delay. The consequences of denied care are not abstract. 60% of patients whose claims are denied report a measurable decline in health during the waiting period. Nearly 1 in 4 never receive the treatment at all. These are not isolated incidents. They are the predictable outcomes of a system optimized for denial. The discriminatory denial. This burden is not evenly distributed. Preventive care is denied at disproportionately higher rates for patients of color, with Asian, Hispanic, and Black individuals facing nearly double the denial rates of white patients. Low-income patients are significantly more likely to have claims rejected than their wealthier counterparts. These disparities are not accidental. They are engineered through bureaucratic filters that ration care along lines of race and class, reinforcing structural inequities under the guise of administrative neutrality. The provider's despair, the moral injury of assembly line medicine. On the other side of every denied claim is a clinician caught in a system that undermines their purpose. Physicians now spend an estimated 20 hours per week on administrative tasks, arguing with insurers, coding for reimbursement, and justifying care that should be self-evident. This is not mere burnout. It is moral injury. The psychological distress of being forced to act against one's ethical obligations. It occurs when doctors must prescribe inferior treatments due to coverage restrictions, when they must delay care they know is urgent, or when their clinical notes become tools for billing rather than healing. The toll is profound. U.S. physicians experience burnout at rates 82% higher than the general workforce. The practice of medicine has become, for many, psychologically unsustainable. The final squeeze. Independent practices, already strained by administrative overhead, are being absorbed by corporate healthcare conglomerates, often the same entities that control insurance markets. This consolidation transforms physicians from autonomous professionals into employees whose primary accountability shifts from patient outcomes to corporate profitability. This is the human damage, a dual crisis in which patients are bankrupted and neglected, and providers are demoralized and displaced. The system does not merely fail to heal, it actively harms. Health becomes a commodity. Healing becomes incidental. This chapter exposes a simple truth. The system isn't failing. It's succeeding exactly as intended, for the few who profit from it. If this hit a nerve, share it with someone who needs to see the architecture of the problem. Move forward to the next chapter. The deeper we go, the clearer the pattern becomes.